Oh my God, are you okay?
Oh, that's gotta hurt.
Leave it, but...
I haven't ever been present for something quite as dramatic as a scalpel going into somebody's foot, although it's certainly within the realm of possibility. My name is Dr. Reed Caldwell. I'm the chief of the emergency department at NYU Langone's hospital in Manhattan, the Perelman Center for Emergency Services. I've been working in EMS, or emergency medicine, since 1999. Today, we're going to look at scenes from the Pitt and judge how real they are.
Allergies! Take it!
You got yourself a fight bite.
While I am sure you are in the clear for rabies and HIV, human mouths are filthy.
A fight bite is the wound that occurs when one individual punches another and it strikes their teeth and their mouth. We make sure that the skin is intact and there's no wound. And also because different from some other regular lacerations, like if you cut your hand with a knife making dinner, that's a very different bacterial environment than if you cut your hand hitting somebody's mouth. The bacteria in mouths, humans, cats, dogs, is packed full of bacteria that can cause rapid bad infection.
We need to determine if the bite extended into the joint space. If it did, you're going to need IV antibiotics and a trip to the OR to see a hand surgeon.
As was demonstrated here, the other part of a fight bite is that you can actually push that bacteria into the joint. So not only do you have a skin infection, but you can also have a joint infection. It's dangerous and a big problem if the infection is in the joint. It can quickly spread and become much worse.
I am going to inject some sterile saline into your knuckle joint. If it comes spraying back out of the bite wound, we'll know. Ready? There she blows.
The steps in this scene are accurate. I think in most emergency departments, a hand surgeon or orthopedic surgeon would be pretty quickly involved as a consultant.
Probably she'll be seen as soon as the provider is available.
But how can they become available if new people keep cutting the f***ing line? I'll take my chances.
The violence in healthcare and violence in the emergency departments is sharply on the rise. I find this clip incredibly accurate, both just in kind of the general volatility. After the patient punched the nurse in a horrifying way, he dropped the AMA form on the ground. AMA means against medical advice. Most patients want to understand what's happening with them. Because patients are frustrated or because other factors in their life are occurring, some elect to leave against medical advice. I give this clip a 9.
What about the rash?
It's more prominent on the lower body, not much on the face. Do you know what this is?
Nope. Resuscitate first, diagnose later.
The thing that immediately jumps out to me is that the patient presents with altered mental status, fever, and rash, and that none of the staff are in appropriate PPE. I would expect them to be have N95s on. I would expect them to be in an isolation room. I would expect there to limit the amount of staff to only essential team members at the bedside. So to me, that's a little inaccurate.
You ever seen anything like this before?
Nope.
Me neither.
Well, that just goes to show you how old I am. This looks like measles.
I don't know exactly how old Dr. Arabi is, but I would guess that he actually isn't old enough to have seen a lot of measles, either personally or professionally. So I found that comment interesting also. With measles, unfortunately, on the rise in the United States, and with the number of serious infections that can present initially as fever rash, we are really sensitive to listen for that and to look for that. For us in the emergency department, the key to measles is immediate recognition and isolation. There's very little around that's more contagious than measles, so we need to be sure that patients are immediately placed in appropriate isolation spaces, and we protect ourselves and our team with the correct PPE.
A spinal tap?
I've read about kids who've been paralyzed from a spinal tap.
There is zero risk of paralysis.
The fear of paralysis from a lumbar puncture is something we hear here quite often. It is a safe procedure. We do not put the needle in the spinal cord. We are putting the needle into the spinal column, which houses the fluid that we need to sample.
Aim for the umbilicus.
Oh, about to pop.
That's the supraspinous ligament. Enter slowly. Next pop is the ligamen flavum.
Lumbar puncture is a procedure where a needle is introduced into the patient's lower spine. We put it in just far enough to reach the spinal canal, which is connected to the patient's brain, cerebral spinal fluid. Lumbar puncture can be utilized to quickly rule in or rule out a number of different infections that impact or affect the brain and spinal cord and can present as fever and/or rash and/or altered mental status. And that can also include measles. However, in this case, they're also ruling out meningitis.
It's going to take a minute to collect, but the fluid looks clear.
That's good, right?
Coming out. Nah, all done.
There's the comment about clear fluid. Clear fluid is telling us that the cerebral spinal fluid is without evidence of blood and is without evidence of white blood cells. If it were kind of murky and cloudy, it would tell us that there are a lot of white blood cells in there, like you may see in bacterial meningitis. The portrayal of the lumbar puncture was accurate. It looked to me to be in the right space with the right equipment, and we saw the clear cerebral spinal fluid coming out. I rate this clip a 6. It pains me to say it because I do appreciate how vaccine hesitancy and emergence of measles in the United States is addressed here. The measles vaccine is safe and effective and important to prevent the reemergence of this serious disease.
Okay, you're gonna feel a little pinprick here.
Ah! Meat!
You put in an IO? Yeah.
IO stands for intraosseous, which means inside the bone. So we have a drill with a very sharp peg on it, where we can actually drill into a bone surface. IOs are utilized when we are not able to find IV or intravenous lines.
Dr. Robbie said everyone gets an IO. If they are unconscious or unresponsive.
If the patient is awake and alert, it's just a standard IV, not an IO.
It does surprise me that this fourth-year medical student grabbed the IO and placed it in this patient alone. I think this is the reason why I tell our med students and residents, please let me know before you begin any procedure. There are some studies that have shown that patients that are awake actually can tolerate it. I think we all just think we wouldn't want that to happen to our own bodies while we're awake, and so we generally reserve them for patients who are unresponsive or in cardiac arrest. In the large majority of patients that we see, we have time to find an intravenous line. If we have difficulty with the intravenous line, our next step would be to use ultrasound before placing an IO in a patient.
Next finger, molecular. My middle finger will guide the tube.
The placement of the endotracheal tube, where he was facing the patient and using his fingers and placing it blindly, is very uncommon in the emergency department setting. When we think of controlling patients' airways, we think of plan A, plan B, plan C, plan D. I think that a blind digital intubation would be quite a ways down that list. Because it's an MCI, they were likely working without standard equipment immediately available, but I would think in an emergency department of this size that there would be some airway equipment that can be tried.
But if you hit the esophagus, he's toast. You told us never to pass the tube unless we see the vocal cords.
If I stay in the midline, I should be able to get it past the cords.
The discussion around placing the tube in the esophagus is important because that's really how you fail at intubation. The esophagus leads to the stomach, and a tube placed there would not be ventilating the patient. An unrecognized esophageal intubation can quickly lead to death, which is what he was referring to. I rate this clip an 8. I take 1 point off for the IO placement into the patient who was sitting up, awake and talking, and I take 1 point off for the blind digital intubation.
It's on the chest tube. Fifth intercostal space, anterior axillary line. Perfect.
The location that was called out and where the incision was made is a standard location for chest tube placement. Axillary meaning armpit, so it's in on the side of your body in line with the armpit, and then the intercostal spaces refer to the spots in between the ribs, counting from rib 1 here down. The chest tube needs to be placed between the ribs because we're trying to access the space outside the lung, just behind the ribs. That's a muscular space where we can penetrate with our instruments in the tube.
Oh my God, are you okay?
Oh, that's gotta hurt.
Leave it, but...
I haven't ever been present for something quite as dramatic as a scalpel going into somebody's foot, although it's certainly within the realm of possibility in this kind of high pressure, high speed environment. The scalpel, which is very sharp, dropped at that height, I assume that it could penetrate this sneaker. This is a reason why in healthcare settings we wear closed-toed shoes in order to help protect against injuries of our feet.
Can I draw your blood?
You already did.
I mean, for the HIV and hepatitis panels.
The fact that she continued on with the procedure after the knife cut her foot would be her decision. When a needle stick or a contaminated cut like this does occur, it's really important that the wound site is immediately washed and cleansed. We generally start post-exposure prophylaxis, or PEP, in order to protect the patient from HIV.
Can I suture for you?
No, I'll do it myself. You can assist. Set me up a Chucks, suture tray, betadine, irrigation saline, syringe on splash guard, and 5-Proline.
The list of items that she was asking for to self-suture was incredibly accurate. What is less accurate is the fact that she's planning to do it for herself. Most people, when they have an occupational exposure like this, would register as a patient. A lot of my colleagues do like to self-treat. In this situation, I would encourage her to check in, become a patient, and be cared for as such. I would give this an 8. I think the knife into the foot can happen, but may be a touch dramatic.
Hold compressions.
Asystole. Resume compressions. Slow tempo.
Should I intubate?
We really don't use hands-on defibrillation, hands-on paddles anymore. We now use defib or pacer pads, which are adhesive pads onto the patient's chest. One thing that I really appreciated was the attention to chest compressions. The scenario where Dr. Robbie asked him to slow down his chest compressions is very common, and it occurs regardless of the level of training of who's doing the compressions. There's obviously a lot of adrenaline. It's a tense situation, and it's hard to know exactly what your rate is unless you're looking at the monitor. Chest compressions right around 100 per minute provide the optimal fill time for the heart. So if you're going way too fast, it limits the fill time, and so you're really limiting your compression's ability to circulate blood through the body.
You ready to call this?
Not yet. Dr. Robbie said 3 rounds of epi. It's time. Let's push another amp.
Deciding when to end a resuscitation or terminate a resuscitation is really multifactorial. Key decision points are what rhythm the patient is in, how long the patient has been down meaning without pulse and breathing, how long resuscitative efforts have been underway.
What? I think I just broke some ribs.
It means you're doing it right.
It is true that ribs are commonly broken even during effective, appropriate, well-performed chest compressions. In adults, we are pushing the sternum down about 2.5 inches, and sometimes the cartilage that is on either side of the sternum and connects to the ribs can dislodge or break, and the ribs can crack as well. I would give this a 9. I really appreciate the attention to excellent high-quality CPR. If I'm being really nitpicky here, the reason why I took 1 point off is because of the paddles.
Hit the external
We
iliac.
stopped the bleeding near the leg, but she's still bleeding internally. We need Mal.
No, we need to give a unit of blood and move her to the red zone.
Okay, let me see if they have space.
This scene is quite accurate. The patient was triaged to the yellow team, which is kind of the mid-acuity team. Red patients require immediate resuscitation. In mass casualty incidents, there's a triage process where patients are given a tag, a color based on the acuity of their injuries and their clinical appearance, stability.
What are you doing?
Prepping for Reboa.
Are you crazy? Did Abbott approve this?
He said, do what you have to do.
A resident, particularly a junior resident in this situation, would continue to resuscitate, and the attending should be immediately involved when there's any large procedures being performed. It is uncommon for a junior resident or a resident to place a Reboa without the supervision of an attending physician or surgeon. Reboa is a catheter that can be placed into the groin and goes up into the aorta, and a balloon is blown up, and the goal is to stop bleeding, so it'll cut off the blood flow in the area past the balloon.
That's a piece of cake. All right, guide wire and introducer sheath.
Whoa, radial's much stronger now.
This scene fairly accurately portrayed Reboa placement. It is an excellent life-saving tool that can be utilized in the emergency department setting, although it's temporizing, which means it's not in any way a permanent solution. The problem isn't fixed. You're just controlling bleeding. As they demonstrated, I would expect the Reboa balloon to go up. Blood continues to be delivered through the IV lines, and the patient has a recovery of their hemodynamics, their blood pressure, their heart rate.
Okay, you never should have done that on your own, ever. Do you understand? That was pretty badass. You saved your life. Good job.
It probably should happen sitting down outside of the clinical space. I think it was important that he let her know that this was potentially very unsafe and should not happen without an attending involvement. I think particularly in this MCI situation, it's also great that he acknowledged that her actions likely saved this patient's life. I give this clip a 9. It shows prompt, accurate resuscitation for hemorrhagic shock.
Live wire hit his left forearm. Shocked him once for VFib.
Transitions of care are really important, from the pre-hospital team to the ED team, and I really liked the handoff from the helicopter team to the ED team. It was a accurate, concise report into that addressed what was going on with the patient and what had been done.
This is the path to avoid the median nerve and all major vessels.
They're about to perform a forearm fasciotomy. Using the marker to identify the incision site is something that happens and is important. We think about the procedure, we think about the anatomy.
How much pressure?
Just about this much.
It does make sense that this procedure would happen on a patient who's been electrocuted. Fasciotomies are needed when a patient has compartment syndrome, and when there's injuries to those tissues, there can be significant swelling inside, which can cut off blood flow because of the pressure on the blood vessels. Emergent fasciotomy, which they're showing in the clip, release the pressure and allow the blood to flow. The amount of pressure that's needed on the scalpel will be determined by the location on the body, the type of injury, and the appearance and condition of the skin and tissues that you're trying to cut through. I'd rate this clip a 10.
Robbie, we need to intubate here.
Dr. Adamson just went down with a pulse ox of 65.
In this clip, we see Robbie having flashbacks from the COVID-19 pandemic and his work in the emergency department, taking care of patients who can't breathe and are dying of COVID, and him feeling overwhelmed by the patients that he can't save. I think this clip is exceptionally accurate and represents a lot of what my teammates and colleagues have gone through in the last 5 years. We in the emergency department are known for dynamic environments. We are known for resilience, and the COVID pandemic really tested that in a way that many or most of us haven't experienced before.
Why couldn't you save her? I mean, this is what you do.
The appearance of the emergency department during his flashbacks to the COVID pandemic looked quite accurate to me. I recall being in a similar hot, sweaty spacesuit for many hours. Despite being around many people and having it be kind of a dynamic, even chaotic environment, I recall also it being very isolating because it's hard to hear. It's hard for people to hear me. You lose contact and touch with your patients and with each other. One thing that clip reminded me of was being with my patients when they were dying. Their families weren't allowed in the emergency department, and so I would hold a phone up to my patient who was dying so that their family outside, either in the parking lot or at home, could be with their family on FaceTime. I give this clip a 10.
We're not ready to let go yet.
I may have to honor his advance directive.
No, you have to honor our durable power for healthcare.
The patient has a DNR, or a do not resuscitate order, and his daughter is attempting to override it. I do exactly what Dr. Robbie did, which is try and guide the family to have them not think about their own wishes, but think about what the dying person wants in that moment. I try and really move away from paperwork and legality and really move into a role of partnership with patients and their families. There are a number of instances where the patient wishes stand. One example is organ donation. So if you have organ donation on your driver's license, that has told everybody that those are your wishes, and that can happen.
A couple drops under your tongue.
Sometimes when you pull the breathing tube out, the patient doesn't begin spontaneous respirations and will die immediately. Many other patients have what we call end-of-life breathing or agonal breathing, but it's often shallow, irregular, so sometimes very slow. Maybe there will be a pause, maybe then there will be a couple shallow, fast breaths. The drops that he placed under the patient's tongue, I would guess, are glycopyrrolate. Patients that are having agonal breathing and are nearing the end of their life, glycopyrrolate can help dry up some of those secretions, and so the patient is less likely to be choking on saliva and having problems managing their secretions. I would rate this scene a 10. I think that it's incredibly accurate.
Drug-seeking woman kicked off a city bus for disrupting and disturbing passengers.
When this patient first arrived in the emergency department, she was screaming out in pain, and there was an initial impression or initial quick judgment that this patient it was because of substance abuse and not her serious sickle cell disease.
I'm doing a retrospective chart review on our past 5 years of patients of color. We don't treat sickle cell here as well as they do in other hospitals, but I'm hoping to change that.
Sickle cell disease are abnormally shaped or misshapen red blood cells, and they can become stuck or lodged in various parts of your body. So it can cause lack of blood flow. Patients presenting in sickle cell crisis can have normal vital signs, and the only complaint is severe pain. The most important data point is what the patients are telling us. So it really requires us to connect with our patients, to listen to their history, and to address their pain immediately and aggressively, much like is demonstrated here. Sickle cell disease very predominantly affects African Americans. Disease processes that are specific to one gender or one ethnic or racial group are really important for us to pay attention to with regard to our own biases and ensuring that we continue to treat all patients like they're our own family members.
What you did in there, building a relationship with your patients, earning their trust, it's what this is all about.
Earning trust with your patients can be a little bit different based on the patient and the situation. The fact that this doctor spent so much time with the patient and her partner, listening to them, showing empathy, taking a history and understanding the patient's disease course, helped the team understand what was going on and recognize the critical illness that was happening. I would give this clip a 10. It nicely demonstrates the bias that exists in healthcare. It demonstrates the way sickle cell patients can be treated, misdiagnosed, or symptoms undermanaged. I would give season 1 of The Pitt a 10. I love the portrayal of the societal issues that are very real and are happening today. I really appreciate the way that different roles in the emergency department, whether it be the charge nurse, the medical student, the attending physician. I love the way that those are accurately portrayed and how everyone works together as a team. And then the medical speak is spot on. My friends and I talk about this at work. We are sometimes even surprised that our non-medical partners and family members are enjoying the show so much because of all of the accurate descriptions and language that's used. I have 2 favorite scenes from The Pitt. The first is the sickle cell case. I really appreciate that this show is calling out bias and racism. I really appreciate that the show is showing us all that in healthcare in the United States, we still have a ways to go. The second scene that I appreciate the most is Dr. Robbie responding to his flashbacks from the COVID pandemic. I think this speaks to reasons for burnout. It speaks to difficulties with resilience, and it's a charge for people like me to keep working on the wellness of my team. If you like this video, why not click on the next one?